Welcome everybody to session number 3 of Clinium number 13. What many people don't know is that 13 is actually a lucky number, not in Europe and in the US, but in China. And there it means definitely vibrant and assured growth. And I think both of these actually apply to both Clinium and to cancer immunotherapy. My name is Twan Lammers. I work at the University Clinic of RWTH Aachen in Germany, and I will be chairing this session together with Ayla Hoppe from the lab of Professor Willem Mulder at the Technical University in Eindhoven. Session number 3 is entitled Unlocking Cancer Immunotherapy's Full Potential with Nanomedicine, and it is packed with a truly outstanding lineup of speakers. The first talk will be 20 minutes, plus some 5 to 10 minutes of Q&A, and then the other talks will be 12 plus 3 minutes of Q&A. Questions will initially be done centralized, so therefore please the button below the presentation screen in the live stream. There you can enter questions, and then Ayla and I will read them out and discuss them with the presenter. Then at the end of the session, there will be a virtual debate in Zoom. The link has been provided also in the virtual room, where we can discuss things more freely and almost in person. So we'll now start off with Professor Alexander Eggermont, who is the Chief Scientific Officer at the Prinses Maxima Center for Pediatric Oncology in Utrecht in the Netherlands. He previously worked at the Gustave Roussy Cancer Center in Villejuif near Paris, where he set up this massive program for early clinical stage drug development and immunotherapy translational research. What many people actually don't know is that he also made some fundamental contributions to classical drug delivery, working with isolated limb perfusion and TNF-alpha therapy to really locally enhance small molecule treatments of sarcomas, for instance, with melphalan. Today, though, he will talk about the next immunotherapy revolution, moving up from advanced to adjuvant and neoadjuvant. Professor Eggermont, thank you very much for contributing to Clinium, and we're very much looking forward to your talk.
So, very good, Twan Lammers. Very nice to be with you guys at Clinium. Unfortunately, not yet in Basel. I will start sharing my screen. And if everything functions correctly, you should be seeing my slides correctly, okay?
Yes, not a presentation
okay.
photo.
Good. I'll make it full size, and now we can move forward. So basically, I want to take the experience in melanoma, where many of the initial discoveries of immune checkpoint inhibitors were made and further developed as a field of the lessons learned from melanoma and the rollout across multiple tumor types, and end up with what is going to dominate the next 5 to 8 years in immunotherapy combo development, the neoadjuvant immunotherapy. So here are my disclosures, and let's get started. Now, you know that in the drug development for melanoma, there were 2 concurrent revolutions. One was associated with BRAF mutant melanoma. This is about 50% of melanomas. There was mutation-driven drug development, the BRAF and MEK inhibitors.
Lex, sorry to interrupt. We're not seeing your presentation mode, so I'm still seeing the first screen.
Well, it's moving forward on my laptop, so I don't know what's wrong then.
I'm still seeing the presenter mode. Maybe we'll just stop screen share and try again.
Yeah.
Now it's working. Perfect.
Now it's working? Ah, yeah. Interesting. Anyway, so as I was saying, BRAF mutant melanoma is about 50% of melanomas. And the BRAF inhibitor, vemurafenib, was the first targeted agent in that field. And in combination with a MEK inhibitor, as depicted in this figure, by a double blocking of that pathway, we basically thought we had found the most important solution to the treatment of BRAF mutant melanomas. But as you can see in the lower corner here, you can see spectacular anti-tumor effects within a week, within 2 weeks, complete responses within 20 days. But as you can see, then you get early resistance patterns, you get relapses and reprogressions already from month 5, 6, 7, 8 onwards. And so in the end, it is a treatment which has limits because of lack of durability. Yet it made an important improvement in terms of overall survival. Look at these numbers at 5 years. No matter which combination of a BRAF/MEK inhibitor you use, you get around 35% 5-year overall survival. And before the BRAF/MEK combination era, this was around 5%. So that's targeted therapy for you. But then the other revolution, of course, was innovative immunomodulation. And this was modulating the immune system and not necessarily a treatment directed against the tumor cells, but enhancing immune system function. And of course, we know that the two big players in there are anti-CTLA-4 and anti-PD-1. Anti-CTLA-4 enhances T-cell priming and therefore prolongs the instruction of T-cell clones, as well as the size of T-cell clones in the lymph nodal compartment of the patient, so that you get a greater variety and a bigger mass of T-cell clones that then can go into the circulation and then can reach the metastatic tumors. There, however, they're running into a wall because the activated T-cells express PD-1, the tumor environment, neutrophils, as we just heard, macrophages, as we just heard, and tumor cells express PD-L1, and the interaction of PD-L1 and PD-1 neutralizes the T-cell function. And so what we needed was to avoid that interaction, and the monoclonal antibodies anti-PD-1 are the most effective ones, and the poster childs are nivolumab and pembrolizumab, and of course the same thing can be achieved by anti-PD-L1 antibodies, of which we have many. Now this together, and because of the fact that these are two completely different mechanisms of action, allows for them to be combined and give an additive anti-tumor effect. And this was all demonstrated in a 3-arm crucial landmark trial, the Checkmate 67 trial, where Nivo 1 milligram per kg, ipilimumab, anti-CTLA-4, 3 milligrams per kg combination was compared monotherapy with anti-PD-1, monotherapy with ipilimumab. So the bottom curve is ipilimumab. The blue curve is monotherapy with anti-PD-1. And the green curve is the combination of anti-PD-1 plus anti-CTLA-4. So what is striking is that you have now 5-year survival rates with monotherapy with ipilimumab of 25%, monotherapy with anti-PD-1 of 45%, and combination therapy of 52%. This 52% of a combo immunotherapy is already 1.5 times better than a BRAF/MEK combo for BRAF mutant melanomas. Okay, so it already shows you that combination therapy is superior. It also shows you that monotherapy with anti-PD-1 with a 5-year overall survival rate of 45% is already as a monotherapy superior to a BRAF/MEK combo therapy. So now in first line, first choice option for all patients basically with advanced melanoma is to start them on anti-PD-1 based therapy, either as monotherapy or if they are young and have no comorbidities and so on the combination of anti-PD-1 plus anti-CTLA-4. So the superiority of immuno-oncology is the main theme in the further developments of the field in melanoma. Look, when you switch ipilimumab 1 milligram per kg in the Keynote 29 trial, which uses pembrolizumab, the other anti-PD-1, overall survival at 5 years is 68.3%. And that 68% is exactly twice as good as 34% with BRAF/MEK combination. So immunotherapy reigns supreme. That is a fundamental lesson from melanoma. That is further enhanced by a trial that was just presented on ASCO plenary series, and that's the DREAM-seq trial. And this regards the optimal sequence of treatments in BRAF mutant melanomas. So here you are. In the left box, you see BRAF mutant metastatic melanoma. These patients are randomized. They either start on the combination of ipilimumab plus nivolumab, then followed by nivolumab monotherapy maintenance. And if they have disease progression, then they switch to dabrafenib plus trametinib. Or they were randomized into dabrafenib plus trametinib to start with, and then at disease progression get ipi-nivo combination. And look at the sensational outcome of how much better it is to give ipi-nivo. That is the black overall survival curve of this trial. And you see that only in the first months, the combination of a BRAF-MEK combo is superior because of the immediate responses. But already at 9 months, there's this crossover, and there's far superiority of having started all patients on nivo-ipi combo compared to dabrafenib plus trametinib. It also means that when you follow the red line, these are the patients who were started on dabrafenib plus trametinib, that they are less responsive at disease progression, which comes in general earlier because the durability of the responses is far inferior. That also then the response rate to the combination of nivo-ipi is lower than what you would have seen normally with nivo-ipi. And so this trial now provides the rationale to basically start all patients, also all BRAF mutant patients, on anti-PD-1 based immunotherapy. And the strongest combination at this point is ipi-nivo. So who made it into the field of immune checkpoint inhibitors? Anti-CTLA-4, anti-PD-1, and recently also anti-LAG-3. Anti-LAG-3 is a checkpoint inhibitor that prolongs T cell function and protects T cell function against exhaustion. But look at the activating receptors. So the activating receptors, so the agonistic antibodies, basically all failed in the development of combo immunotherapy thus far. So it is the checkpoint inhibitors that are have this propensity to be able to be combined and be used in the clinical setting. Here's just the anti-LAG-3 data, which is very recent. Combination of anti-LAG-3, relatlimab, plus nivolumab, anti-PD-1, compared to nivolumab monotherapy, was published this year and recently updated. Light blue curve is the combination. So here you have prolonged T cell function because of anti-LAG-3 compared to anti-PD-1 monotherapy. And this is the overall survival curve. You see there is a relatively small additive effect. In terms of overall survival, it just misses a value that is significant. Hazard ratio is 0.80, but it has as an advantage that it brings much less immune-related adverse events than the use of ipilimumab, anti-CTLA-4. But the top of this slide shows you what is actually, in essence, the big problem. The anti-PD-1s are the Mozarts of our time era of immunotherapy. And it's incredibly hard to break the anti-PD-1 monotherapy ceiling. And just to look at some recent failures in phase 3 trials. So the agonistic monoclonal antibodies, they all failed until now, one after the other. The anti-IDO drug, Cadastat, made it into a couple of phase 3 trials, but failed. Actually, in this trial, pembrolizumab plus epcadostat versus pembrolizumab, the Keynote 252 or ECHO 301 trial, there was no impact on relapse-free or overall survival at all. It was only later that they found out that they underdosed epcadostat, the IDO inhibitor, and that actually there were not pharmacologically effective levels of the IDO inhibitor. So it means that the IDO field is not dead, but that this was basically a failure of adequate dosing. Then there's been 2 intratumoral treatment phase 3 trials, one with the oncolytic virus TVEC, and one with the Toll-like receptor inhibitor tilsolimod. Master Key 265 trial, pembrolizumab, anti-PD-1, plus TVEC versus pembrolizumab alone, showed no impact on overall survival and no significant impact on progression-free survival. And the Illuminate trial, ipilimumab plus tilsolimod versus ipilimumab, did not show any impact significant for progression-free survival or overall survival. And these trials were stopped. And in terms of smart cytokines, there was the BEMPAC molecule. And the BEMPAC molecule was supposed to create much lower levels of T regulatory cells than regular interleukin-2. The combination with nivolumab was tested in the PIVOT-01 trial versus nivolumab monotherapy. And this trial was just also revealed to have no impact on progression-free and overall survival. So that breaking of the PD-1 ceiling is very hard. Remember that. So what is going to be the next step? The next step is, well, what you already heard also in the prior talk is we need to tackle the third compartment of the tumor that is providing all these problems. We have basically with anti-CTLA-4, prolonged CTL priming, and anti-CTLA-4 will remain a very important drug. We have given CTL effector function protective agents with anti-PD-1, anti-PD-L1. This is totally crucial, without which no immunotherapy will go further and will make progress. So that's step 2. Step 3 is what can we do against vastly immunosuppressive actions of tumor-associated macrophages, the M2 macrophages, that downregulate T cell function so effectively. So the myeloid-derived suppressor cells and these tumor-associated macrophages, they have Fc gamma receptor 2 on their surface, with which they can interact with the anti-PD-1s that protect your T cells. And then they pick off the anti-PD-1 protection. So you can avoid that by using anti-Fc gamma receptor 2b monoclonal antibodies. You can also actually change the Fc portion of your anti-PD-1s so that they cannot bind to Fc gamma receptor 2 anymore, and therefore optimize and prolong the protection of your CTL cells at the tumor site. Then you can enhance tumor cell phagocytosis by covering the CD47 ligand on tumor cells, which is a don't eat me signal, with anti-CD47 monoclonal antibodies, or even better, with anti-SIRP alpha antibodies, so that you are not confronted with the problem with anti-CD47 approaches, where you also have to give humongous doses of the antibodies to first saturate all the red blood cells and the platelets in the body before you can actually effectively enhance phagocytosis of tumor cells. And you have repolarizing agents that repolarize M2 macrophages, which are the ones you don't want, into M1 macrophages that actually enhance the Th1 anti-tumor response. And some of those small molecules are CCR5 and some others. And then you have, and I will not go further into this, still then a number of other immune escape mechanisms that are less important in terms of their presence and in terms of the percentages where they are actually playing an important role, and they may be more difficult to deal with. So first of all, we need a checkpoint inhibitor for macrophages. The eternal question is vaccines that were dead, because therapeutic vaccines basically were dead in the oncology sector. What about the second life that vaccines may have? Well, yes, they do, but only in combination if you protect TTLs that they create. I just want to make one remark about a very important trial that has been activated, which is a new concept. It's the Twin vaccine against immunosuppressive cell populations, because it's peptide vaccine with a peptide for the specific anti-IDO epitope T regulatory cells and the specific anti-PD-L1 epitope myeloid-derived suppressor cells. So this is a vaccine not against tumor cells. This is a vaccine that is directed against the two main immunosuppressive immune populations in the body. Interestingly, it gave in 30 advanced melanoma patients an 80% overall response rate, almost 50% complete response rate, and a median progression-free survival rate of 3 years. This was just published 4 months ago in Nature Medicine, and we are now at this particular point in time activating the phase 3 trial in 100 centers all over the world. So the anti-PD-1 molecule is central to everything. It has activity now approved in over 20 different tumor types and in over 100 different indications in first line, second line, and in the adjuvant setting. And we are conducting some 3,000 trials with anti-PD-1 or anti-PD-L1 as the central scaffold molecule in combination with anti-CTLA-4, anti-LAG-3, chemotherapy, radiation therapy, or all those small little circles, which are targeted therapies or the vaccines and the like. So the question then was, what's the next lesson that we can learn from melanoma? From melanoma, we can learn that if you translate what you have seen in the advanced setting into the adjuvant setting, what do you see? And you see, and it's just in one slide, you see that everything that works in the advanced setting also works in the adjuvant setting. So ipilimumab was the first trial to show overall survival benefit in the adjuvant setting in lymph node positive melanoma, hazard ratio 0.75. And then we got nivolumab, anti-PD-1, dabrafenib plus trametinib only for BRAF mutant melanoma, and pembrolizumab, anti-PD-1, all resulting in about hazard ratio of 0.50 reduction, a 50% reduction of relapses in the adjuvant setting in stage 3 melanoma patients. And at the bottom, you see all publications regarding this. So that works. You will have one question before I start on neoadjuvant, and that is, what about ipi plus nivo in the adjuvant setting? Yes, we expect it to benefit, and yes, if you dose ipilimumab correctly, you see a significant benefit in resected stage 4 disease, as shown in the German trial. But in the stage 3 large trial in 2,000 patients, they did something different, and they changed the schedule, and they underdosed ipilimumab to a non-effective 0.5 milligram per kg level, and therefore that trial failed. So it is a bit like the epidostat experience. So neoadjuvant immunotherapy, however, is the way that will change everything in the management, not just of melanoma patients, of various patients with populations with solid tumors. What do we predict? We predict more cures. We predict shorter treatment cycles. We predict less surgery. And all this initially has been worked out in palpable stage 3 lymph node positive melanoma patients and in resectable stage 4 melanoma patients. But simultaneously, also now in MSI colorectal cancers, especially the rectal cancers, the T3 muscular invasive bladder cancers, the locally advanced cutaneous squamous cell carcinomas, the locally advanced lung cancers, and multiple other trials that are ongoing in all domains. So what does it show? So this is the old schedule of adjuvant. You first do a resection of positive lymph nodes, and then you give adjuvant therapy. In neoadjuvant therapy, you first treat with anti-PD-1, the combination of IPI plus anti-PD-1, IPI-NIVO, for instance. And then you do a resection, or the response has been a complete response, and you don't even have to do lymph node dissections anymore. And so what does the data show? First of all, this is a landmark study that makes you understand the principles of neoadjuvant IPI-NIVO in the blue box compared to adjuvant IPI-NIVO in patients with palpable lymph nodes, melanoma stage 3 disease. If you give them neoadjuvant IPI-NIVO 2 cycles and then do the surgery, instead of giving the surgery first and then in the red box give adjuvant IPI-NIVO, and you look at peripheral blood monocytes sampling, and you score for the clones, T-cell clones that were already present at baseline, the darker bars, or the clones that are newly detected, so the induced, newly detected clones. You see the red, dark and light bars, and you see the blue, dark and light bars. And what you show is that the neoadjuvant, it's the blue bars, gives you a much wider new array of T-cell clones, the amplitude of which is also much higher than anything you see in the red bars. So you do not only expand the number of different T-cell clones, but also the multifold expansion, the amplitude is much higher. And this is a recipe for cure, because you need multiple different T-cell clones and you need big armies to cure a patient of its cancer. So now you look at an 83% disease-free 2-year score in these patients with palpable lymph nodal disease. Normally, this is around 55%. If you had a pathologic complete or near complete response, there was only 1 out of 60 patients, it's the green curve on the right-hand side, that relapsed. The little star was a patient who actually died in a traffic accident, and he was free of disease. So we have never, ever in the history of melanoma seen these kind of results. Never, ever. There is a big pooled analysis that scored immunotherapy, anti-PD-1 based, or anti-PD-1 plus anti-CTLA-4 based, that showed that if you had a major response, there was basically no patients that relapsed anymore at 2 years. If you had BRAF mutant melanomas alone and you treated those with targeted therapy, you see that only the patient who had a pathologic complete response did fairly well. But if you had anything less than a complete response, you did as poorly as you did before. So the superiority of immune oncology is again demonstrated in the neoadjuvant setting in melanoma. Now, in this trial, the PRADO trial, which will, by the way, be published in Nature Medicine in about 2-3 months. What they did in palpable lymph nodal disease is they put a little lymph node marker in the largest node. Then they got 2 courses of ipilimumab and nivolumab. Now follow the yellow boxes. If you had a pathologic complete response by looking at the largest node, that was the only node you took out, and you had a pathologic complete response or a pathological near complete response, you did not do any complete lymph node dissection anymore. So no more axillary lymph node dissections, no more ilioinguinal lymph node dissections, no more large head and neck dissections anymore. You just follow up the patient. No more adjuvant therapy and no relapses. So this is the managerial change of patients with palpable lymph nodal disease. So that's what it confirms. It confirms basically that in 60% of patients you could forfeit, you could omit further surgery. So we see the same thing in bladder cancer, and we now have 4 phase 3 trials to avoid vasectomies in patients with muscular invasion of bladder cancer. And look at the MSI colorectal cancers. So in Amsterdam, John Hane did a trial that was also published in Nature Medicine in 2020. There were 20 patients with rectal cancers for which they would have done normally a rectal resection or a rectal amputation. 2 preoperative courses of ipi/nivo gave a 19 out of 20 complete response rate. Now, these patients were still operated. Now, we don't operate these patients anymore. We just take a biopsy. And if it shows only necrosis, we don't touch anymore. We just follow them up with endoscopy and MRI. So in the Netherlands, all those patients that are MSI, colorectal cancer patients, are not operated anymore, but they are treated with ipi/nivo. This is truly a revolution of major proportions. Just approved last month was the combination of neoadjuvant nivolumab, anti-PD-1, plus chemo versus chemo alone trial, the Checkmate 816, which showed that there was a almost 40% progression-free or relapse-free reduction. There was an 11-month median progression-free reduction or relapse-free reduction. And the pathologic complete response rate for the combination was 24%. That is 12 times higher than for monotherapy alone. And in overall survival, there was almost a 43% reduction of death. So also now in lung cancer, neoadjuvant rules. And it will rule also in esophageal cancer and in gastric cancer, I promise you. And so even in glioblastoma multiforme, look here, red curves were patients who had just 1 dose of anti-PD-1 prior to surgery for a relapse of glioblastoma multiforme. Blue curves did not have that 1 dose of anti-PD-1. So it's what it shows and it's what it promises. More cures, shorter treatment cycles, less surgery. That's the message of my talk. I thank you for your attention.
Lex, thank you very much. Fantastic talk. I think it was an update on 3, 4, 5 years of immunotherapy advances in 20, 25 minutes. Since we're already quite a bit over time, I propose that we keep questions for the debate. I hope you will still be available in the debate.
I will be there. Yeah, sure. Yeah, no, I'll be here. I had another meeting this morning, so I could join you only a quarter of an hour late, but I'll be with you for the whole session. Yeah, thank you, Twan.
Fantastic. Okay, then we'll take the questions in the debate, and we'll now move on to the third talk of this session. Will be given by Professor Evangelos Giamarellos from the Internal Medicine Department at the Medical School in the University of Athens. He also works as a guest professor at the Center for Sepsis Control at the Jena University Hospital. I think he made a number of contributions to the fields of drug therapy or immunomodulatory treatment of sepsis, but also cancer immunotherapy. Today, we'll focus on COVID as one of the first paradigms for personalized anti-interleukin-1 therapy. Professor Giamarellos, please, the screen is yours.
Thank you very much for this great invitation and for the opportunity that I deliver a talk on the first paradigm that we have in the field of infectious diseases of personalized medicine, which has been approved by one of the big regulatory authorities. Actually, the talk will not be focused on basic research. It's a clinical research talk. And actually, this is my conflict of interest disclosure for this presentation. And actually, this talk is based on this approval. In other terms, what you see there is that on 16th of December 2021, the CHMP of the European Medicines Agency has announced the approval of Kineret for the management of COVID-19 pneumonia in adults based on a personalized approach. This means that, in other terms, what you need to do is that for patients who are admitted with COVID pneumonia at the emergency department of a hospital or who are hospitalized, you can predict who are the patients who will eventually get deteriorated into severe respiratory failure, who will be in need of mechanical ventilation, and to start them early treatment with the use of anakinra. The next day, 17th of December 2021, it was officially registered throughout Europe. And this is based on a program which was settled and conducted with, from our team. It's a collaboration between Italy and Greece, and I had the honor to supervise it. So, the first question, what's going on with COVID? And as a matter of fact, all of us now, we are a bit relieved because we are now at the climb of the pandemic, or the pandemic overall, or of just a pandemic wave. In other terms, do we need to really focus on this issue? Because still the intensive care units are full of patients with COVID, and still the problem persists if, although from a societal point of view, it is not really all the lights of attention on it. First of all, we need to understand how difficult it is to manage COVID. If you look at clinicaltrials.gov, on 15th of December 2021, there were more than 7,000 trials registered for COVID-19. However, all these trials were aiming to the registration of active vaccines and drugs for management. And look how poor the yield of these trials was. The European Union approved only 3 vaccines, 3 monoclonals, and only 4 drugs for patients who are hospitalized: remdesivir, dexamethasone, tocilizumab, and anakinra. By far, it is the lowest and most disappointing yield of available drugs for patients who are hospitalized. Which means that it's not a problem of our perception. It's the real problem is that the virus is difficult. The life cycle of the virus is difficult, and probably a personalized approach is needed. Look what is happening so far. Inside the circle, you see patients, different patients. They are represented by blue, by green, by gray. All of them arrive at hospital. However, roughly 1 out of 2, probably a bit more out of 2, are at real risk. Risk of what? I will show you soon. All these patients, they get the same therapy. And the risk has 2 edges. At one edge, the patient, in less than 1 week, is deteriorated. He develops dyspnea, respiratory insufficiency. He needs to be admitted in the intensive care unit, and many of these patients die. The other edge of the spectrum, even if the patient does well, this patient leaves the hospital and he is a living dead among us. Why? Because he has jumped into long COVID. There is persistence of symptoms, loss of work productivity, long-term morbidity and mortality, and a lot of absenteeism. So what we should do? We need to early realize at the emergencies where the risk is. In other terms, we need to highlight the patients' risk, to focus on them, and to change our strategy and the traditional way medicine is thinking. What I mean through this. Look what physicians were doing. We're waiting for a diagnosis. We're waiting for a prognosis. We're waiting for symptoms to appear, and then we start treatment. This is what we know from the very beginning from our medical schools. Now, we need to shift gears. We need to change our mentality. In other terms, we should not wait the patient to develop symptoms of getting worse. We need to identify very early in his blood a signal that something will deteriorate, and to start treatment before symptoms appear in order to prevent admission in the ICU, to decrease mortality, and to increase the cure rate. So this is the virus. The virus finds a receptor, which is the ACE2 receptor. Through this receptor, the virus is entering the epithelial cells, and it starts a rapid replication inside the epithelial cells. And as a result of this rapid replication, epithelial cells are destroyed and they release their danger-associated molecular patterns. These are data that we have just published in the Journal of Innate Immunity. And as a matter of fact, in this publication, we divide existing danger-associated molecular patterns into two main groups. One is IL-1 alpha, which is more or less, someone could describe that less as a cytokine, more as a growth factor, which is stuck on cell membranes. And the other is one danger-associated molecular pattern known as calprotectin, which stimulates the production of IL-1 beta. Both IL-1 alpha and IL-1 beta, they act at the level of their cell receptor on the alveolar macrophage, and as a result of this interaction, inflammation emerges. However, there is a big difference of IL-1 compared to all other cytokines. In order to develop fever, we are in need of IL-1. And the more IL-1 you have, the more fever you get. And this is part of the explanation why patients with COVID-19, they are extremely feverish. However, the level of temperature in our body can never exceed a certain plateau. And for this reason, it is mandatory for the alveolar macrophages to produce an endogenous antagonist, which is acting at the level of the same receptor in order to attenuate the excess effect of IL-1 alpha and IL-1 beta. So allow me now to present you a completely different strategy of treatment for COVID-19, a strategy that has the acronym SAVE, and a strategy that has the characteristics of preemptive approach. In other terms, here is the patient who has arrived at the emergencies. He may or may not be in need of oxygen. The patient needs to be screened for a biomarker that can tell that this is the patient that we have in front of our eyes, who's in risk of worsening because he's under an attack of IL-1 alpha and IL-1 beta. And through this, because we know that the patient is now under attack, we need to start immediate treatment in order to prevent the patient to deteriorate. And what could be the best candidate treatment? But of course, a recombinant form of the endogenous antagonist for which I talked to earlier on. This antagonist does exist. The name of the antagonist is anakinra, and it's blocking the action of both IL-1 alpha and IL-1 beta. So the question is, now that we're in need of the biomarker, these are data that we published at the beginning of the pandemic, and you see that these are Greek patients. In March 2020, they arrive at the emergency department of hospitals. On the moment of their admission, they do not have symptoms of respiratory dysfunction, but they are divided in two main subgroups. Those in red, who have a concentrations of the biomarker 6 or more, and those in blue, where this biomarker is less than 6. What's the acronym of the biomarker? SUPAR. This stands for soluble urokinase plasminogen activator receptor. And what you see is impressive. Those who arrive at the hospital with increased SUPAR 6 nanogram per ml or more, sooner or later they jump into respiratory dysfunction, being in need to be admitted in the ICU. The others are not in need of ICU treatment. And we felt extremely happy because these findings were validated into different validation cohorts coming from the United States. And someone may say, why is SUPAR so important? Or if I reside in an environment where SUPAR is not available, how can I get the same information for a patient? As a matter of fact, the advantage of SUPAR is that it gives you an integrating information of 4 different biomarkers: D-dimers, C-reactive protein, ferritin, IL-6. And these 4 biomarkers are the characteristics and the fundamental characteristics of the biochemistry of COVID. COVID deteriorates the endothelium. And as a result, you have coagulopathy, the dimers are increased. COVID is affecting the liver. And as a result of that, you have an increase of CRP, ferritin, and IL-6. However, not all patients with the same degree of severity of COVID, they have the same concentration of all these 4 biomarkers. And if we give different points to each of these 4 biomarkers, we can end up with a score with the acronym SCOPE, which gives to us similar information like SUPER. So you can very easily understand who's the patient who's arrived at the emergencies, either because he has SUPER more than 6 or 6, or because he has a SCOPE score 6 or more. When we had the information about the biomarkers, we started an open label platform-like trial. In other terms, we delivered to our patients standard of care plus anakinra because they had this biomarker increased, or we had patients only a standard of care. And as you see, the result after 14 days is spectacular. Almost 60% of patients under usual care, they developed respiratory dysfunction compared to 22.3% of patients under anakinra. And as it is anticipated, this has a major reflection on survival. Only 11.5% of patients under anakinra die compared to 22.3% of patients under usual care. When we had this data in November 2020, I addressed the emergency task force for COVID-19 of the European Medicines Agency. I received from them their feedback about the design of a pivotal, double-blind, randomized phase 3 trial. The acronym of this trial was SAVE MORE. It was published last October at Nature Medicine, and allow me to acquaint you a bit with the features of the design of this trial. Again, the same patient population, patients with pneumonia, patients with COVID, of course, infection, who have concentrations of SUPER 6 or more. And they are randomized, and they receive for 10 days either standard of care containing dexamethasone plus placebo, or standard of care containing dexamethasone plus anakinra sub-Q 100 milligrams once daily. The primary endpoint was the allocation of the patients to the 11 strata of severity of the WHO CPS, for which I'm about to talk to you right now. So, after 20 days, the health state of a patient may be reflected by one of these colors. As a matter of fact, you have 5 main colors: gray, meaning that the patient has fully recovered; green and 3 shadows of green, which reflects long COVID; yellow, which means that the patient remains under oxygen in the general ward; orange, which means that the patient remains in the intensive care unit; and red, which means that the patient has died. The primary endpoint is expressed as an odds for worse outcome under anakinra compared to placebo. The odds is 0.36, which means that there is a 64% overall benefit. And as a matter of fact, this outcome has 2 edges. The one edge is the full resolution of COVID. No symptoms, PCR negative, and this is increased by 64% under treatment with anakinra. And the other edge is to remain in the ICU or to have died. And a patient is protected by a relative protection rate of 54% after treatment with anakinra. The real main concern of all clinicians with biological treatments is the risk of secondary infections. These are our cumulative, emergent, serious treatment adverse events. In blue are patients under placebo, in red are the patients under anakinra. I would like that you focus your attention on the incidence of the total infections and infestations: 15.9% in the placebo group, 8.4% in the anakinra group, And that was anticipated. Why? Because if you treat with anakinra in a personalized approach, guided by the biomarkers, you prevent admission in an intensive care unit. And if you prevent admission in an intensive care unit, you prevent the worst side effect, which is ventilator-associated pneumonia. So, if with the current standard of care, we have 2 patients who will be fully cured, these are increased to 5 if we add on top of the standard of care anakinra. If we have 1 patient asymptomatic PCR positive, these patients are increased to 3 if we add anakinra. If we have 5 patients that are long COVID, they decrease to 3 with anakinra. If we have 2 patients hospitalized, either with oxygen in the ward or in the intensive care unit, these are decreased by 50%. If we have 2 patients who have died, we manage to save from death 1 patient. And someone now may ask, I have a patient in front. I want to know what to do. And the answer is clear-cut. This is the path towards deterioration and admission in the intensive care unit. The patient is originally infected by the virus, and at the beginning there is a rapid replication where the patient has symptoms and where monoclonals and molnupiravir are indicated. Some of these patients, they progress into a pulmonary phase. They have signs of radiological signs of pneumonia, either in chest X-ray or in computed tomography, and they have hypoxemia. From these patients, some all of a sudden, and this sudden means from 6 hours to 2 days, they deteriorate and they are in need to be admitted in the ICU. They are mechanically ventilated. They are at extreme risk of death. And there, the effect size of available drugs, we know that already, is relatively small. So what we need to do, we need to understand from those who are hospitalized and who are in need of oxygen, those who are at risk. We should not wait until they have signs of dyspnea. And how we do that by using the biomarkers I talked to you. And if these biomarkers are positive, there is no time of thinking. We need to start immediate anakinra treatment. And as you see, with this approach, the numbers of patients needed to treat are far lower than any other registered drug. Thank you very much for your attention, and I'm looking forward to the discussion.
Thank you for these outstanding contributions. I'm looking at the chat to see whether there are 1 or 2 short questions. Not yet. Maybe I'll start off myself. So how rapid can the SUPAR-based diagnosis be done? So ideally, say
20 minutes.
20 minutes, fantastic. And I know that in the past decade, there were quite some studies looking at SUPAR for various different types of inflammations and infections. So now it really seems that it has finally found its way into the clinic as a biomarker. Is that correct?
This is correct. So far, it was just a non-specific biomarker of unfavorable prognosis. But having just a biomarker telling risk does not mean anything. The real importance is to have a biomarker not just telling you the risk, but telling you the pathway which has been initiated inside the human body. And the earliest you inhibit this pathway, the most of benefit you will get for your patient.
Yeah. Okay, so we'll take the other questions forward to the debate later on. I hope you'll still be available.
Of course I will.
Thank you very much. I'll pass on to Ayla to moderate the remaining 3 talks. Ayla, please.
Yeah, thank you. So the next talk will be given by Professor Ronit Sachi-Fainaro. She's the head of cancer research and nanomedicine laboratory at Tel Aviv University. And she's also the director of the Tel Aviv University Cancer Biology Research Center. Her talk today will be about off-the-shelf nanomedicine for brain malignancies. So please, Professor Sachi, take it away.
Thank you, Ayla and Twan, and of course to BIOTRIP for forming this wonderful conference and really exciting new talks that I've just heard, and all of us. Do you see my screen well? Is that okay?
Yes, we do, yes.
Thank you. So I will take all the wonderful data and the wonderful background that all the previous speakers gave and maybe connect them to the nanomedicine world. And I will start with the green numbers of the attrition rate, when we all know that we started the discovery stage with 10,000 compounds, and within 15 years, we get to one FDA-approved drug. So very long time and very poor attrition rate. And if this is not enough, the numbers of the cost is about $2.6 billion to get all this through until approval. And this is updated to December 2021. And if this wasn't enough, if we look not from the discovery stage, but from the clinical stage, from phase 1, there's only 11% of drugs that enter clinical testing will be approved in the US. And this is down from 16% from 10 years ago. So we're not even getting better. And the question is why? And this is the incentive of a whole project that started about 6 years ago in my lab, because we are focused on oncology, and in oncology it's even lower. We see 5%, 5.3% is the likelihood of approval for a compound that starts from phase 1. Immunotherapy is a bit better, is around 13%, but still these are really low numbers and very expensive. So we wanted to address this challenge and maybe see the reason as the models being wrong models. We all know that we use cancer cells alone on 2D and 2 dimension, grown on plastic, rigid plastic that has nothing to do with the tissue where the tumor was originated from. It doesn't have the microenvironment, it's not in 3D, and it doesn't have the extracellular matrix that characterize the mechanical properties that we are well aware of the fact that they affect the way that the cells, the cancer cells with the microenvironment will respond to different drugs. So the way to address this was to join forces with neurosurgeons at the lab. I will focus my talk on brain malignancies, primary as glioblastoma, and brain metastases of lung, melanoma, and breast cancers. And the idea was to get from them the MRI, to do the image analysis on the day of the surgery, to get a piece of the tumor, and then I create cell suspension of all the cells, the cancer cells, together with all the microenvironment cells, meaning if this is the brain microenvironment, so we have the endothelial cells and pericytes of the blood-brain barrier, we have the astrocytes, the microglia, and we immerse them in a hydrogel that mimics the tissue of interest, where in this case the brain and the mechanical properties of the tissue, meaning the stiffness, elasticity, plasticity, and so on, and to create by a sacrificable gel the blood vessels where we can flow the PBMCs of that same patient, the peripheral blood mononuclear cells. So what you see here in this very crowded slide is a bleb of a brain, but inside, following 17 hours of confocal screening, you can see that there are blood vessels that are made of the isolated endothelial cells in red, pericytes in light blue, cancer cells, in this case it's glioblastoma, you can see in dark blue, astrocytes in green, and microglia that are not labeled, but they are there. So this allows us to see a whole 3D brain with a 3D tumor in it. And you can see that within 2 months, it creates a life of itself and creates this vascular network of the blood-brain barrier. And since we create the blood vessels, according to the MRI, you can see that in a Z-stack confocal, they have a lumen. So we can connect them to a peristaltic pump and flow through them the PBMCs of that patient and different drugs and combinations of drugs, those drugs that my peers just discussed, and especially immunotherapy, where we used to, even if we did co-culture on a plate with immune cells or endothelial cells, this was in 2D on plastic, or if it is in PDX, patient-derived xenografts, they are implanted in immunodeficient mice. So we cannot test all these wonderful hypotheses of combination immunotherapy. And here you can see that, in these movies here, you can see that, imagine you have a 3D tumor in red. These are the tumor cells that are only labeled, but we have all the microenvironment cells. Here we have the PBMCs that were activated, for example, with anti-PD-1, and you can see how they destroy the cancer cells. And in this case, you can see and predict by staining, following treatment, we stain the T cells in green, the CD8 T cells, and if they infiltrate, we can predict that this immunotherapy will work and will have, this patient will respond to this immunotherapy, as opposed to when we don't see this staining infiltrating, meaning no T cells were cytotoxic T cells infiltrated. This is only one example of a whole immune profiling that we use for 40 multiplex of 40 different markers. So if we go back to 3D printing, this field, I think we live in a really exciting era where 3D printing, advanced technologies, advanced data science of all forms of omics. If we look at proteomics, RNA sequencing, whole exome sequencing, and in general, single cell sequencing, and we use all that to find new targets and then address those targets by developing either a small molecule or using nanomedicines, nanoparticles. We wrap, if there isn't a drug that exists or an antibody that exists, we use CRISPR to knock it down, as we saw earlier that inhibitors worked much better than stimulators in immunotherapy. So all this sequencing and data that we accumulate together with the 3D printing has advanced significantly in the last decade, with even 4 companies originated specifically for 3D bioprinted cancer models. So if I take this to a concept of an hypothesis that we developed while thinking why melanoma, breast cancer, and lung cancer end up with occult, the 90% of these advanced patients end up with occult tumors in the brain, metastasis, which is supposed to be the most protected site. The idea was that maybe cells that are leaving the primary tumors circulate in our blood while secreting pro-inflammatory cytokines. Those cytokines end up in many different organs, but they need resident cells to be activated and respond by secreting other cytokines. In this case, in the brain, is the microglia and the astrocytes that are activated. They secrete pro-inflammatory cytokines that cause astrogliosis and microgliosis and neuroinflammation. We heard a lot about the neuroinflammation before because of COVID, but also here in cancer, we see a lot of similarities, and this causes the hyperpermeability of the blood-brain barrier, allowing these circulating cells to form these, again, occult tumors in the brain, and after that, to start recruiting the microenvironment, blood vessels, and immune cells. And while we created these models that mimic this scenario, we developed nanomedicines for, like nanovaccines for prevention, intervention, polyplexes of nanoparticles with siRNA or mRNA if we want to express a certain cytokine, and the nanomedicines that co-deliver to existing drugs at a synergistic ratio, allowing the synergism to be exerted while we force them to have the same pharmacokinetics arriving to the tumor at the same time, being released by an activating enzyme, in this case cathepsin, that releases both drugs at the same time, exerting their synergistic activity. And this platform was based on polyglutamic acid, where we used it for both as companion diagnostic for image-guided surgery at real time and for the therapy using BRAF and MEK inhibitors. So starting with the image-guided surgery, where we give our probe like 1 hour before the surgery, and at real time, we're able to see, the surgeon is able to see it, because when they, due to threat, being first in close proximity, the 2 dyes or a dye and like a Cy5 and a black hole quencher, once they are cleaved and being further away from each other, they emit near infrared light with that wavelength. And we see that we are able to double the survival from 40 to 80% because we make sure that all the cancer cells were removed at a very precise manner. And the ones that were under white light sent metastases to the brain, as can be seen here with our probe. So moving forward to therapy, because we know that we might still miss some of the circulating cells, cancer cells, we move to the idea of the tumor host interactions in the brain, where the main component that I will talk about will be the microglia, and Eilam Yaini in my lab, a wonderful postdoc, show that in all the cases, both models, in vivo models and in patients, the microglia is activated as we predicted in our hypothesis, while in normal healthy brains, both of human murine models, patient-derived xenograft, and in patients directly, we don't see them being activated. And we see that the more microglia we add to the cancer cells, in this case, the glioblastoma cells, we see exactly the same with the brain metastases that I mentioned. We see that the more microglia, the higher the proliferation rate, and the more microglia we add, again, we see higher migration and invasion rates. And we wanted to see who is in charge, who is the cytokine that is the driver out of a whole proteomics essay that I will not talk about it in this talk today, but the one that we saw to be the driver one and not a passenger was p-selectin, which is an adhesion molecule, and the p-selectin ligand, we show that both are overexpressed in brain malignancies. So the cancer cells secrete p-selectin, and the microglia respond by secreting p-selectin ligand. And using molecular methods, either SH or CRISPR inside a nanoparticle, and also a small molecule inhibitor that was put inside the nanoparticle to be delivered to the brain, we saw that we were able to rescue this phenotype by inhibiting proliferation and migration, mainly by rescuing the M2-like phenotype of the microglia back to an M1 phenotype. And this resulted in inhibition of tumor growth of orthotopic model of glioblastoma inoculated intracranially, and prolongation of survival. So we were very happy with these results, but we can always see that there are some that escape this therapy, and like many other therapies in clinical trials and in the clinic in general. And for that, we wanted to add a nano vaccine to it using a neoantigen of glioblastoma, while using a PLGA PLA nanoparticle that is decorated by mannose to be able to target the dendritic cells that have CD206, a mannose receptor, and internalize to the dendritic cells following intranasal administration. See that the journey to the lymph node, they express the MHC1 and MHC2 complexes via the two peptides that we internalize in our nanoparticle, together with a TLR9 agonist, CpG, and an siRNA of PDL1 that is supposed to shut down and knock out the PDL1 expression, not in the tumor cells, but rather in the dendritic cells that we see that they confirm the immunosuppressive microenvironment when they reach the tumor. So we are activating both the cellular and the humoral immunities by CD8 T cells that are being activated against the neoantigen, and CD4 activating B cells that produce very high affinity at the germinal centers, high affinity neutralizing antibodies to the neoantigen that we chose. And this is how it looks, the nanoparticle. It's about 170 nanometer size that was optimized to reach the lymph nodes following intranasal administration or sub-Q, where we wanted it to reach the lymph nodes, and the mannosilated nanoparticles accumulate preferentially compared to the non-mannosilated. And we see that in melanoma brain metastasis, we get inhibition of tumor growth and prolongation of survival, especially when we add ibrutinib that eliminates a BTK inhibitor that eliminates the myeloid-derived suppressive cells, the MDSCs that are correlated with poor response to immunotherapies. And we can see that what we created here is a very specific response to the antigen of interest, looking both by ELISpot and by a tetramer assay that we got from the NIH tetramer facility. And that we can see that now we have extended it to many different cancer types with different antigens, whether they are neoantigens or known antigens, and even created a nanovaccine for COVID-19 using this algorithm, selecting a very specific MHC1 and MHC2 peptides that together with the siRNA to PDL1, and this is intended for third world countries because there is no need for cold chain. No, it's needle-free. It's always a powder delivered to the third world. And combining the two approaches, we took the nanovaccine to the neoantigen of the glioblastoma together with the P-selectin inhibition. We see that we get in our 3D models and in the mice that express that neoantigen, tumors that are inoculated intracranially, we get prolongation of survival in a very aggressive type of glioblastoma. And finally, if I take this very basic work in the lab from in vitro to in vivo and then to ex vivo with the patient samples, a few months ago when we published this work in September 2021, we, in the same time, Novartis just got an approval, FDA approval for an antibody to P-selectin for sickle cell pain crisis, nothing to do with glioblastoma or brain metastasis or cancer in general. And we started a compassionate use on a single patient. Never believe a scientist telling you about N=1 of a single patient, but I think this is really promising. Starting, she was diagnosed in July, started therapy with the antibody to P-selectin in October, and this is her MRI from March, and she's doing really great. She got already 6 treatments, including April, and she's doing really well. So this is the first patient. We are starting now a cohort of 30 patients for both brain metastases in combination with anti-PD-1 and for glioblastoma as a single therapy, showing you hopefully that we can start from the patients, take it to the biologists and the data scientists in the lab doing all the omics, then taking it to the chemists in the lab to produce the nanomedicines and hopefully taking it back to the clinic. I want to thank all my wonderful group of scientists and clinicians in the labs coming from biology, medicine, engineering, and chemistry, and of course, the wonderful collaborator from different agencies and the funding agencies. Thank you very much.
Thank you very much, Professor Sachi. So I think in view of time, it's best that we move on to the next talk. And the next talk will be from Professor Jérôme Gallon. He is the Director of Research at INSERM, which is the French National Institute of Health. Unfortunately, he couldn't be here today live, so this will be a pre-recorded talk from him, which will be about integrative tumor immunology. So let's start the presentation.
I would like to thank the organizers for inviting me, and I will discuss today the role of the integrative tumor immunology to understand cancer and the oncology. Here are my disclosures. I'm the co-founder of RWTH, now a Veracyte company, and Chief Scientific Officer, Immuno-Oncology, and I talk to people in industry. When we started working on cancer, we wanted to really address the question about the complexity of human cancers by considering human samples, large cohorts of patients, and not focusing on a particular cell or on a particular molecule, but trying with genomics and immunomics and systems biology to get an integrative view of the tumor immune microenvironment. What we found, which was back in the early 2000s, and this is first the definition of cancer. As you know, cancer is based on the tumor progression within the primary tumor, the T stage. It's based on the tumor invasion, the N stage, and the metastasis, the M stage. It's based on tumor aggressiveness, and the key parameters of tumor progression, invasion, the recurrence, really defines what is an early stage or what is considered an early stage cancer versus a late stage cancer. And of course, the severity of the disease and the treatment according to these types of classification. However, what we showed is a novel paradigm in which it's not only about the cancers, the tumor cells, but about the immune contexture of cancer that we called. In fact, what we found is that there is a pre-existing immunity, and we have very different tumors. You can have hot immune tumors, cold immune tumors, and those will behave very differently. In fact, all the key parameters of tumor progression, tumor invasion, the recurrence of cancer are all dependent upon the pre-existing immunity of the patients and about the immunoscore of a patient, which is a standardized way of measuring the adaptive immune cells. In fact, the fate of the tumor cells is dependent upon pre-existing immunity. The fate and the survival of the patients is dependent upon this immune contexture of the cancer. And also the likelihood of response to immunotherapy is also dependent upon this pre-existing immunity. The basis for this was in this article that we published in Science, where we define, was the foundation for this concept of immune contexture, and we defined the key parameters that are associated with the survival of the patients. They consist in 4 parameters: the types of immune cells, the density of these immune cells, so a quantitative measure, the location, where are these immune cells within the tissue and within the tumor, and these first 3 parameters are measured by the immunoscore assay. And the 4th parameter is the quality of the immune response, which is the immune functional orientation of the response, which can be measured with immune signatures like immunosign. In fact, the novel paradigm came when we did the multivariate analysis, putting the strongest and the gold standard parameter, the T stage, the progression of cancer, the N stage, the grade of differentiation, in a Cox multivariate model to test the strength and the dependency of the parameters. So together with the immunoscore, and as you can see, not only the immunoscore is highly significant on a multivariate analysis, but all the other parameters are no longer significant and are in fact statistically dependent upon the immunoscore of the patients, the pre-existing immunity of the patients. So the key important parameters of the immune contexture are the cells, the types of immune cells, the quantity that can be measured by the densities of these subpopulations, the spatial information, that is the location, where are these cells, and the quality of the immune response with the immune functional orientation of the response. In fact, this is an evolving thing because the tumor cells are constantly changing, are proliferating, and the immune cells are reacting to that. And so we wanted to understand really the relationship between the evolution of the immune response to cancer and the tumor progression by using systems biology. And we analyzed the spatial temporal dynamics of the immune response with tumor progression by looking at large cohorts of patients at all the stage of T stage, so T1, T2, T3, T4, knowing that there was a kinetic and a progression from T1 to T4. And we published that in this immune landscape, which was the first time where we showed the immune landscape of human tumors in this immunity article. In fact, we characterize what we call the immunome, that are the signatures of immune cells from purified immune cell subpopulations, so all the different subsets of immune cells, and you can see very distinct signatures specific with specific genes specific for each immune cell type. And we can apply this immunome to get a deconvolution of the tumor microenvironment and get the information about these types of immune infiltration through deconvolution of bulk RNA. Of course, we need validation, which was done here by doing a real quantitative measurements of immunohistochemistry, so the staining of specific immune cells, and digital pathology to quantify in the different regions of the tumor the different types of immune cells, like the T cells, this big peak of CD3 positive cells here, which were quantified in yellow at the invasive margin of the tumor, or in blue in the center of the tumor. And you can see the major cells in terms of density. You can see the network of cells, the subnetwork between the two regions, and cells that are outside of these networks of immune cells. We discussed the fact that there is a continuum of cancer immunosurveillance, and also the fact that depending on the immune response intensity and quality, we have a core of immune contextual parameters that are not only predictive, but also prognostic, as well as mechanistic. When there is a response to immunotherapy or therapy, the same immune parameters are increased upon response. And we discussed and published articles along the lines of the continuum of cancer immunosurveillance, before cancer, from precancerous lesions to primary tumors evolution, up to the metastasis and the continuum of cancer immunosurveillance through all these steps. First, starting with primary tumors, it has therapeutic insights, of course. The situation in clinical routine, all hospitals worldwide, is the following. There is a cancer classification that is done that is only based on tumor cell characteristics, the TNM staging system, tumor extension and invasion, anatomopathology, tumor morphology, the grade of the tumor cell of origin, tumor molecular pathway like macrosatellite instability, for example, tumor gene signatures, or the tumor mutation status. Is it a P53 mutant tumor or a KRAS mutant tumor? In terms of the patient, the immune-based classification, the host immune response, until 2019, there was none. Nothing was done. The clinicians didn't know anything about the immune system of a cancer patient. Now we have a diagnostic test that is measuring the adaptive immunity of a cancer patient that is called Immunoscore. The Immunoscore was a worldwide validation with a worldwide consortium with all these countries involved into this validation, a lot of assays, harmonization, and the results of the study were published in the Lancet International Validation of the Consensus Immunoscore for the classification of colon cancer patients, which is the first standardized immune test that quantifies the immune densities, immune infiltration of tumors, and classify patients according to the risk based on the Immunoscore. And in fact, the Immunoscore has such a power that in fact it is above all the previous gold standard parameters, including the N stage, the T stage, the grade of differentiation, etc. And in Cox multivariable analysis, Immunoscore in 2 categories, high, low, 3 categories, high, intermediate, low, or 5 groups. All p-values for Immunoscore are below 0.0001 in multivariate analysis. And in fact, in 2019, December 2019, for the first time in the WHO book for digestive tumors, the immune response was recognized an essential and desirable diagnostic criteria, citing the Immunoscore as best evidence. And in 2020 and in 2021, the Immunoscore was introduced into the European Clinical Practice Guidelines for Gastrointestinal Cancer and the Pan-Asian Guidelines, both for its prognostic and predictive value of response to chemotherapy. What about pre-cancer? Well, in fact, what we noticed was that if you look at the T stage, the earliest stage, T1, the in situ T1, is when the patients have the highest densities of adaptive immune cells, cytotoxic T cells, the highest immune response. And so it means that there was an initiation of that response before. And so we analyzed pre-cancer lesions in lung squamous carcinoma by taking heavy smokers at risk of developing cancer with all the stages pre-cancer, hyperplasia, metaplasia, maldysplasia, severe dysplasia, etc., and characterize the immune microenvironment of these pre-cancer lesions And this led to this article published in Nature, Immune Evasion Before Tumor Invasion in Early Lung Squamous Carcinogenesis. When we analyze all these genes, they have different patterns, and we analyze the co-inhibitors, the checkpoint, the immunosuppressive cytokine, we noticed that these were increased before the carcinoma stage in late grade pre-cancer lesions. And in fact, we can summarize this by the following. In low-grade dysplasia, there is already an immune sensing and unleashing. In high-grade dysplasia, before cancer, there is an immune activation, but also an immune escape with immune checkpoint upregulation. What about now metastasis? Well, what drives really metastasis? What are the immune metastatic escape mechanism? And is it compatible with the theories of cancer evolution? So we looked at stage 4 metastatic patients and looked at more than 600 metastases, either in the lung or the liver, coming from colorectal cancer primary tumors. We published a first article in Cancer Cell looking at the multiverse of immune microenvironment in metastases and multiverse of tumor cells within the different metastases. And we looked at the survival of these patients. And as you can see, patients with stage 4 disease, metastatic disease, the immunoscore measured in the metastases of these patients showed dramatic difference in terms of survival. Patients with a high immunoscore, good immunity, have a much better overall survival, 70% survival at 5 years, or has only 20% survival if they have a low immunoscore. Also, in this article published in Cell, we looked at the evolution of metastasis in space and time and showed that it was under immune selection. In fact, the current theories of cancer evolution, there are 4 different models: the linear model, the neutral model, the Big Bang model, and the branch model. All these theories are tumor cell centric because none of them involve a possible role of the immune system. And we try to address this question by taking patients having a long history of synchronous metastasis as well as metachronous metastasis with more than 11 years follow-up on the patients, did a lot of multi-omics technology, and showed the evolvogram of the tumor clones, how they change from the primary tumors and how they are disseminated within the synchronous and then the metachronous metastasis. And we noticed that, in fact, there are some non-recurrent clones that are immunoedited, whereas the progressing clones, which are transferred from one metastasis to the next, are immune privileged. And we found that the significant parameters to predict the likelihood of transmission and recurrence are the following: immunoscore, the immunoediting of the immunogenic mutations, the distance, the spatial distance between T cells and proliferating tumor cells, and the bad part is the size of the metastasis associated with the proliferation of the tumor cells. And in fact, we have now a model and different types of metastasis with different mechanisms of immune escape associated with the immunity of the patients. And in fact, now we are proposing an alternative model that is a parallel immune selection model, where the dynamic interaction of tumor cells with immune cells and a Darwinian selection of the immune escape variants is happening with a parallel evolution of these cells. So in fact, we discussed how to treat patients and how to treat differently patients with an immune hot tumor, an immune altered tumor, or a cold immune tumor, with different combinations of different immunotherapies depending on the immune alterations of the patients. We applied this also in the context of CAR T cell treatment, and now I've shown that not only the type of CAR T cells that is infused is important, but even more importantly, the pre-treatment, pre-existing immunity of the patient, the pre-existing immune contexture is essential to predict the likelihood of CAR T cell to work in cancer patients. If you're interested in learning more about tumor immunology, the field of cancer, and the tumor evolution. You can read this immunity article where we describe the major steps of tumor immunology and cancer immunotherapies, and also our latest cancer Nature Review Cancer, where we discuss the immune contexture and the immunoscore, both for cancer prognosis and therapeutic efficacy, with an immune view of cancer that is completely different from the classical view of oncologists based on intrinsic characteristics of tumor cells and based on different types of indication, cancer indication. There are common features in terms of the immunity across multiple different cancers. And with that, I'd like to thank all the people in the lab, to thank our sponsors, and especially to thank all the centers in the world who participated into the validation of the immunoscore. And I thank you very much for your attention.
Okay, that was a great talk by Professor Jérôme Gallon. Because this is pre-recorded, it's not possible to ask any questions, unfortunately. So let's move on to the last talk of this session, which will be given by Professor Zheng Gu. He's the Dean of the College of Pharmaceutical Sciences at Zhejiang University. The presentation will be on bioresponsive drug delivery. So please take it away. Okay, that was a great talk by Professor Jérôme Gallon. Because this is pre-recorded,
all right,
it's not possible to ask any questions.
Can you hear me okay?
Yes.
Yeah. Okay, great. So thanks so much for the introduction, and thanks so much for the invitation. It's my great pleasure to share our studies, especially in such a fabulous conference. So I will talk about bioresponsive drug delivery. Part of our work is supported by Sanofi and our own startup company, the capsule, especially for cancer immunotherapy, and the Xenomics for glucose-responsive insulin delivery. So as you know, that in our body associated with the specific diseases, specific organs, the physiological signals could be different from these kind of normal conditions or most tissues organs in terms of the absolute concentration or relative gradients. So then we can leverage such difference to promote the release of drug at the right time, right places with the relatively correct dose. For example, we can leverage this kind of acidic environment associated with tumor microenvironment and develop some like acidic sensitive materials and later on to engineer the specific formulations or devices, typically like nano or micro structures, and then to deliver such systems to the tumor microenvironment. And under such like a acidic environment, they can be degraded, dissociated, or swelling or shrinking, and to promote the release of drug, especially to enhance the treatment efficacy and meanwhile potentially to reduce the systemic toxicity. And for other diseases, for example, the diabetes, we can leverage the enhance the glucose level to promote the release of the insulin. For the wound, even like a stroke sites, you can also identify the different physiological signals as a trigger to promote the release of drug. And regarding the design philosophy, we are very interested in using the bio-inspired or biomimetical design. So here's like two directions. One way is like we can directly apply the biological particles like cells, bacteria, even like a virus as a carrier to deliver drug. And we are very interested in using the platelets as a drug carrier. And I will give you some examples later. And meanwhile, we can use the synthetic materials as a carrier to mimic the function of such bioparticles. Especially, we develop like glucose responsive smart insulin patch to mimic the function of the pancreatic beta cells, and they can sense the glucose level and to release the insulin at the right time, especially once the blood sugar level goes high. So such patch like this, it's like just a quarter-sized patch, and can well control the blood sugar level of type 1 diabetic pigs, especially with the weight of, like, for example, 25 kilograms. So this is actually really clinical relevance. So we are currently translating this technology, especially we already registered the clinical trial, associated with the FDA websites, and we are currently recruiting patients. And this could be a broader platform technologies like the microneedle array patch, like they can sense the glucose level to release the insulin, and meanwhile, they can also deliver different drugs locally, and meanwhile can also go through like a lymph system, also like this kind of the blood system, the capillary to the whole body to achieve the systemic treatment efficacy. So based on this, for example, we developed this kind of heparin patch, which can release the heparin at the right time once the thrombin level goes high, and to reduce the risk of the stroke. And also smart cell patch, we can put the live cells into the patch for the different applications. Recently, we launched a new startup company called MicroZine Pharma, especially for the application of cosmetics. For example, we can change the shape of the patch and can wrap it around the swab and can easily destroy the pimple or acne. And not only to the skin, also can be applied to the heart, and especially for treating myocardial infarction. And for the cancer treatments, this is our recent publication, especially for the biomarkers associated catalysis application. So we can put for example, the PD nanoparticles. This is actually a catalyte, can convert the drug to the active format of the chemotherapeutic drug. For example, the here's like doxorubicin, and then actually we can put such catalytes, the PD nanoparticles, to the microneedle array patch, and the aim is like to reduce the toxicity of the PD nanoparticles, because this was toxic and somehow can limit the application of this catalysis in vivo. And then, once we put such catalytes into the patch, and we can apply the patch to the tumor directly, certainly can be associated with like a skin cancer, or you can put such patch, through some like a catheter and can put it inside. And then, you can inject the drug like systemically, especially pro-drug with low toxicity. And once it, interact with the tumor cells and especially interact with the PD nanoparticles, they can be activated to form the original format of the chemotherapeutic drug. So that means it can produce the drug locally in situ inside the tumor gradually in a sustained way, and then to boost the treatment efficacy. And after that, you can just simply remove the patch or remove the device and to reduce the toxicity. And for the cancer immunotherapy, you can also put the protein or like a nucleic acid into the microneedle array patch. So here's like we can put the checkpoint inhibitors like a PD-1, PD-L1 antibodies, also like a CTLA-4 antibodies into the microneedle array patch. You can also like put them into the micro like particles first, like a PRGA based, and then load it to the microneedle array patch, and then to perform the sustained release of the drug from the microneedle array patch. And with this way, you can enhance the retention time of the immune checkpoint inhibitors, the antibodies, into the tumor. Certainly also associated with, for example, here's like a melanoma. And then the local concentration is like boosted, and then the systemic dosage can be potentially reduced to reduce the side effects. So regarding the delivery of the immune checkpoint inhibitors, we are also very interested in using this kind of cellular carriers to deliver them. especially we developed the platelet-based carriers to leverage their natural targeting capability toward bleeding site, the inflammation sites. So then we can bring the drug, for example, to the surgical sites. Okay, clinically, once surgeons to remove this kind of tumor, sometimes it's really hard to completely to remove all the tumor tissues. And if some micro tissues there, some residual tumors there, and after surgery, especially on the inflammation environment, they can quickly develop the tumor recurrence. So then during surgery, we can infuse the platelets with the drug. Here's for example, PD-L1 antibody. So then they can target to the bleeding sites associated with the surgery. And meanwhile, platelet is very unique. They can form the platelet-derived microparticles after activation, and then can boost the release of drug from the surface of the platelets. And certainly you can also load the drug inside the platelets, right? Through this kind of physical adsorption. Here, just based on the standard bioconjugation method. And meanwhile, during the activation, the certain chemokine, cytokine can be also released and can also help the recruitment of the T cells to achieve the systemic, this kind of synergistic effect. So here's in situ, you can see the thrombin can activate the platelet and to form such smaller particles, especially with size around 100 nanometer, and to boost the release of drug from the platelets. So they can well target to the surgical sites. And in a mouse melanoma model, we demonstrated that they can significantly inhibit the tumor recurrence after surgery, especially compared to the control groups, just infuse the platelets without drug or just infuse the antibody to the mice. And they can also help inhibit the tumor metastasis, just associated with lung tissues. And meanwhile, we can also add such drug loading platelet to the HSA, to the hematopoietic stem cell, especially for treating tumor recurrence after the AML associated chemotherapy. And we can actually here's put the PD-1 antibody to the surface of platelets. And now it's HSA actually can serve as a GPS to guide the platelet with drug to the bone marrow based on the homing capability of the HSA. We can apply the clinical reaction to conjugate the platelet to the HSA. And we can adjust the ratio between the HSA and the platelets to achieve the so-called cell-cell conjugates, okay, and over 50% of the HSA, one cell with one platelet conjugated, and won't affect the homing capability of the HSA. And once they arrive at the bone marrow sites, the platelet can be activated and the drug can be released. And in addition to the systemic treatment, we are also interested in using such a gel scaffold to load the cells inside to perform the local release of cells from the polymeric scaffold. Yes, especially we applied the hyaluronic acid as the major material to form the such a scaffold. And inside we can load the CAR-T cells also together with the drug loading platelets. And then they actually somehow can work together. Platelets can go faster and they can stop bleeding, and meanwhile can also release just a PD-L1 antibody. And then the CAR-T cells can also released outside in a sustained way. And with the help of the PD-L1 antibody, somehow they can interact with the tumor cells, and then with the help of the CAR-T cells, the overall treatment can be also promoted. Not only for inhibiting the tumor recurrence, but also they can also targeted to the metastasis sites. Here's another example. We can also fabricate this kind of porous microneedle, and then later on we can load the CAR T cells. Since I just talked about the CAR T cells based treatment, so we can load the CAR T cells into the porous structure of the microneedle, and then we can somehow directly seed the CAR T cells toward the solid tumor, and especially here's like for treating pancreatic cancer, pancreatic tumor, especially to promote the expansion as well as the activity of the CAR T cells associated with the pancreatic tumor. Back to the platelet-based treatment, we can get the platelets from the blood bank. Also can simply from patients themselves, and after simple separation, we can load the drug to the platelets, to the surface of platelet, also like inside. And then we can go back to the patients and then can well target, for example, the surgical sites. And now we can also expand the applications to the different situations. And this is actually the major pipeline of the Z capsule. And we can also genetically engineer the platelets to allow it to have the certain protein highly expressed. And the platelets, they don't have the nucleus. So we can start with MK cell, and then we can transfect the certain plasmid DNA inside, and later on to get the platelets, for example, highly expressed with the PD-1 receptor, not an antibody. Here is the PD-1 receptor. And inside the platelets, we can load the drug, for example, the cyclophosphamide, especially to inhibit the Tregs. And then we can infuse such platelets with drug inside, and especially also for treating the tumor recurrence after surgery. And then after activation, they can form the smaller platelet-derived microparticles with the PD-1 receptor highly expressed. And then PD-1 receptor can interact with the PD-L1 ligand associated with the tumor cells, and somehow can work as the PD-L1 antibody. So that means here, platelet not only can serve as the carrier, but also can achieve the therapeutic performance. And then we can also allow the platelets to have PD-L1 highly expressed, just like a PD-L1 ligand. And then we can apply such platelets for treating autoimmune diseases, especially for treating the new onset type 1 diabetes. Certainly, such platelets can also target to the inflammation sites associated with the pancreas of the mice with the new onset type 1 diabetes. And then after the several injections, the increased blood sugar level can become normal, especially on like, for example, 200 milligram per deciliter. And we are also interested in other formats of cells. For example, we can load the drug to the lipid droplet of the adipocytes, and especially to leverage the metabolism pathway of the lipid, then to boost the treatment. So due to time limit, I just quickly go through. And also we can make this kind of dead cells from the cancer cells. We can freeze the expanded cancer cells, and not for store them, but to kill them. We can quickly increase temperature, and we can prepare such dead cells from the cancer cells. And the structure, overall structure is still there, and we can load the chemotherapeutic drug inside, for example, doxorubicin, and the tumor-associated antigens somehow still there, and also certain protein which can target to the certain tissue site can be also remained, and not only for the control release of the drug, but also can serve as the cancer vaccine. And also some other cases, for example, we can apply the the injectable gel, also like the sprayable gel, okay, locally for treating the tumor recurrence after surgery. And here's like for delivering the CD47 antibody locally to enhance the efficacy and meanwhile to reduce the toxicity. All right, so I always encourage my students to learn from nature for designing this kind of carriers. Okay, like a platelets, like this kind of glucose responsive insulin patch. And I put like 3 pictures here. The first one is like the X-ray, this kind of diffraction image of the DNA. So people just understood the DNA structure like 70 years ago. Okay, and second one is like the certain structure of the virus. So based on the invention of the TM, people just understood the structure of the virus probably like around 70 to 80 years ago. The third one is like the first picture of the black hole. So that means our understanding associated with ourselves, associated with the nature, as well as the universe is still like a very superficial. So based on this, a lot of things can be learned from nature. Okay, for drug delivery, enjoy fun and make impacts. So with that, I would like to thank my students, wonderful collaborators, and terrific support from the funding sources. Thank you so much. And welcome to Zhejiang University, okay, in a beautiful city, Hangzhou in China. Thank you so much.
Thank you very much for a great talk, Professor Gu. Let's see if there are any questions coming in. I don't think so. So I actually had a question because, yeah, you have all these very advanced and very innovative materials to deliver these platelets and CAR T cells to the tumor. I was wondering, have you also looked at the infiltration of these cell therapies into the tumor?
Yes, so great question. So especially regarding the CAR T cell, based therapy for treating solid tumors, we are very interested in characterizing this kind of infiltration degree regarding CAR T cells towards solid tumors. So we actually tried different ways. One way is like I just introduced, we can directly seed the T cells into the solid tumor, by such like a microneedle or a patch. And certainly you can also apply some other devices directly to put the cells into the, the tumor, especially to disrupting this kind of physical barrier, okay? And this is one way. And another way is like also very quite interesting. Several years ago, we found that, if you locally heating the tumor, for example, by the photothermal therapy or by ultrasound, okay? And then you infuse the CAR T cells. After that, we found that the infiltration of the CAR T toward the solid tumors can be significantly increased. And this could, partially due to the generation of the tumor-associated antigen, based on this kind of, the killing of tumor cells, and certainly also like to release the danger signals, based on the like a photothermal therapy or the locally heating. And also such heating may expand the tissues a bit, also certainly associated with the vessels. So this is another way. And also the scaffold locally, you can apply the scaffold like based on the hydrogels, to the tumor. So we actually tried different ways to boost the infiltration, especially based on our understanding for the CAR T therapy, this kind of disruption of the physical barrier could be very important.
Okay, thank you very much. There are no questions coming in right now, so I think it will be nicest for everyone if we go on to the debate lounge now. So first, I would like to thank all the speakers today very much for their contribution. Also on behalf of Twan Lammers and Beat Luffler. So please, everyone, join us in debate lounge number 1. It's the button below the live stream, and there we can have a nice discussion between all the speakers and participants. Thank you very much.